So let's begin with this question here. A 45-year-old male with diffuse back pain and chest tightness. A lateral cervical radiograph is shown. What is the probable diagnosis? So they have given you a lateral cervical radiograph and they're asking you what is the diagnosis in this 45-year-old male with diffuse back pain and chest tightness. The options are Ankylosing Spondylitis, DISH. What does DISH stand for? Diffuse idiopathic skeletal hyperostosis, Klippel-Feil syndrome, or is it a Sprengel's deformity? Now, before we come to the correct answer, let's try to break this down. Let us try to understand the imaging finding of all of these options given here. Let's start with the image given here. Please look at this chest radiograph. This is a frontal chest radiograph showing you a high-lying scapula. You can see the scapula here, and this scapula is high-lying, right? So this high-lying scapula, which is elevated and rotated, this suggests what is called as Sprengel's deformity. So this indicates there is what? Sprengel's deformity, a congenital defect where there is failure of migration of the scapula from the mid-cervical region to the mid-thoracic region. This failure of migration leading to a high-lying scapula is called as Sprengel's deformity. In many of these patients, almost about 35% of these patients of Sprengel's deformity, you also see a bony bar or a fibrous bar that can be present between the superomedial angle of the scapula reaching out to the cervical spine. So this bony area present from the superomedial aspect of the scapula towards the cervical spine, or it could be a fibrous bar also. This is called as your omovertebral bone. So omovertebral bone is seen associated in almost about 35% cases of Sprengel's deformity. Look at this 3D CT image. You can see this is the 3D CT image, and you are seeing a high-lying scapula. You can see this high-lying scapula. The scapula is elevated, rotated, and can you see this bony projection? What is this bony bar that is uniting the superomedial aspect of the scapula to the cervical spine? This is again your omovertebral bone. So this is the things that you need to remember about Sprengel's deformity on the imaging. So do remember, Sprengel's deformity is a congenital defect where there is failure of migration of the scapula from the mid-cervical region to the mid-thoracic, so it remains elevated and rotated, and there is a high-lying scapula in Sprengel's deformity. And there is this omovertebral bone that we saw in about 35% cases. Do remember, Sprengel's deformity can be seen isolated or commonly associated with even Klippel-Feil syndrome also. Klippel-Feil syndrome is also commonly associated with Sprengel's deformity. They can occur together in most patients. Before we go into understanding the other diseases here, let's look at the normal anatomy of the vertebral column. So you can see here, these are the vertebral bodies. These are the intervertebral disc areas, right? Here is the intervertebral foramen. These are your apophyseal joints, right? So these are the apophyseal joints. And anterior to the vertebral bodies, you have the anterior longitudinal ligament. So you can see the vertebral bodies. This is the intervertebral disc, and on the anterior aspect of the vertebral bodies, you have an anterior longitudinal ligament. And just posterior to the vertebral bodies, you have the posterior longitudinal ligament. So you should understand what is anterior longitudinal ligament and the posterior longitudinal ligament. With this normal anatomy, let's look at a cervical spine radiograph. So if you look at the lateral cervical radiograph and try to identify the structures here, this is a normal lateral cervical radiograph. And what are the structures that you can identify on this image? If you see the structures that you can identify on this image, I hope you can see this bony area here. This is the hyoid bone. Can you see this lucency of the track here? right? So this lucency or the dark area that you are seeing is the tracheal lucency. Behind it, this is the prevertebral soft tissue. The prevertebral soft tissue is less than 7 mm at C2 level, and it is less than 22 mm at C6 level. So I'm teaching you how to look at a normal lateral cervical radiograph. You should identify the hyoid bone. You can see the tracheal lucency. This is the part of the epiglottis here. So this is the epiglottis. You are seeing this soft tissue area. This is the prevertebral soft tissue. This is the prevertebral soft tissue, and you should know its normal dimensions at the level of C2. So please look at here. This is the dense, right? So this is the C2. This ring like vertebra here, this is the C1. So at C2 level, the prevertebral soft tissue is at less than 3 mm in thickness. And at about C6, this is C3, this is C4, C5 and C6. At C6 level, normally it should be less than 22 mm. And I also want you to identify the apophyseal joints, right? So I hope you can see on the posterior side, these are the spinous process. And I hope you understand the anterior vertebral line. This would be the posterior vertebral line. Let me show you a labeled image here. So you can see the labeled image here. You can see here, this is the hyoid bone. This is the part of the epiglottis, the tracheal lucency, the prevertebral soft tissue, which is less than 7 mm at C2 level and less than 22 mm at C6 level. You can identify the vertebral bodies and the intervertebral disc space. You can see this line here is the anterior vertebral line, and this line here, this is the posterior vertebral line. You can see the spinous process and the posterior elements of the spine. So this is a normal lateral cervical radiograph. So please identify how to look at the intervertebral disc space and the vertebral bodies. Let's now come and look at this radiograph of the spine. So on this lateral cervical radiograph, do you think is it normal or is it abnormal? If you see carefully, you can identify that the vertebral bodies appear to be fused. The cervical vertebrae are fused and there is not much intervening intervertebral disc space. So when you have this fused cervical vertebra with absent intervertebral disc space, please think of Klippel-Feil syndrome. Think of Klippel-Feil syndrome where we have fused cervical vertebra, right? And this Klippel-Feil syndrome has a classic triad. What is the triad of this Klippel-Feil syndrome? You have a short neck, you have a low-lying posterior hairline, and in these patients you also have limited neck mobility. So this clinical triad suggests this is what Klippel-Feil syndrome. So Klippel-Feil syndrome has fused cervical vertebra, a low-lying hairline and limited neck movements. And most of these Klippel-Feil syndrome, as I told you before, are associated with a high-lying scapula, that is Sprengel's deformity. So you can see here, right, there could be a high-lying scapula associated Sprengel's deformity. So let us review Klippel-Feil syndrome. Klippel-Feil syndrome has a clinical triad of short neck, low-lying posterior hairline as well as limited neck mobility. These patients have fused cervical vertebra. There will be absent intervertebral disc space between the vertebral bodies. And also they are associated with vertebral dysplasias like hemivertebra, and do remember its association with Sprengel's deformity. Moving on further, let's see how ankylosing spondylitis would appear. If you look at a healthy spine, these are the vertebral bodies and this is the disc space. These are your apophyseal joints. In ankylosing spondylitis, there is inflammation, sclerosis, decrease in the intervertebral disc space. There is also fusion of the bones, right? There is decrease in intervertebral disc space, fusion of the bones, and a classic finding called as bamboo spine. And also there will be fusion or ankylosis of the apophyseal joints. What is the earliest joint involved in ankylosing spondylitis? I hope you remember the earliest joint involved is a sacroiliac joint. So let's see some of the imaging findings of ankylosing spondylitis. Now look at this lateral cervical radiograph. What do you think is this? Is this Klippel-Feil syndrome? No. Please concentrate carefully. I hope you are able to see the intervertebral discs in between. Right? These are the vertebral bodies, and I hope you can appreciate the presence of the intervertebral discs there. The intervertebral disc height is decreased. The height of the intervertebral disc is decreased, and they are also calcified. The periphery of the intervertebral disc, the annulus fibrosus, is calcified, but the intervertebral disc space is there. In Klippel-Feil syndrome, you do not see this intervertebral disc space, right? There is fusion of the cervical vertebra. And also, can you see posteriorly, the apophyseal joints are also ankylosed. They are also fused. So when you see decrease in intervertebral disc space, ossification or calcification of the periphery of the annulus fibrosus, the apophyseal joint involvement on the lateral cervical radiograph, please think of ankylosing spondylitis. Ankylosing spondylitis also has osteopenia. There is demineralization of the cervical spine. And look at this another example of a patient with ankylosing spondylitis. Look at the cervical spine. I hope you can see these are the vertebral bodies. You can see the decreased height of the intervertebral disc spaces, the calcification of the periphery of the intervertebral disc, and also try to look at the apophyseal joints. Try to look at the overall mineralization of the spine. It is decreased. And you can also see some spinal fractures developing here in this patient. So when you see demineralization of the spine, when you see that there is ossification of the intervertebral disc, the periphery of the intervertebral disc, right? So these are the vertebral bodies, and the intervertebral disc peripherally are ossified, giving the appearance of the bamboo spine. And also you see that there is decrease in the intervertebral disc space. Think of ankylosing spondylitis. We all know some important radiographic findings of ankylosing spondylitis. Please look at here again. There is sclerosis and decrease in height of the intervertebral discs. There is this syndesmophytes. There is ossification of the anterolonginal ligament, mineralization under the anterolonginal ligament, producing a more squarish appearance of the vertebra. There is vertical syndesmophytes that occur, right? All of this indicate ankylosing spondylitis. So this kind of appearance that you have, this suggests a bamboo spine. So this indicates a bamboo spine. Here you are seeing in ankylosing spondylitis, there is calcification noted in the interspinous ligament. This calcification of the interspinous ligament is called as what? Dagger sign. So this dagger sign, which is indicating the calcification of the interspinous ligament, this ossification of the annulus fibrosus, right? Periphery of the annulus fibrosus, the intervertebral disc, this sticking together along with the calcification of the interspinous ligament, this is called as trolley track sign or tram track sign of the spine. And look at this image. This is an MR image. The bones are dark in MRI. So this is an MRI image. And what sequence of MRI? Look at the subarachnoid space around the spinal cord. So this is the spinal cord here, and around the subarachnoid space is hyperintense. So this would be what? T2 weighted MRI. On this T2 weighted MRI, in the intervertebral disc space, are you able to identify these hyperintense areas involving the intervertebral disc spaces? These hyperintense areas which are present indicating inflammation of the intervertebral discs in cases of ankylosing spondylitis are called as Anderson's lesions. So these are the Anderson's lesions. So all of these are the different findings that we see with ankylosing spondylitis. Another good example of a bamboo spine here, you can see the ossification of the intervertebral discs, right? You are seeing the peripheral ossification of the intervertebral disc, the dagger sign. Along with that, you get this appearance of a bamboo spine in ankylosing spondylitis. The important feature of ankylosing spondylitis is there is mineralization of the anterolonginal ligament. Along with that, there are also these vertical syndesmophytes, right? Osteophytes would be more horizontally oriented, but in cases of ankylosing spondylitis, you have this vertically oriented syndesmophytes. And there's also mineralization happening just under the anterior longitudinal ligament that fills up this concavity here, making a square shaped vertebra. So there will be squaring of vertebra also, squaring of vertebra noted in cases of ankylosing spondylitis. And these are your vertical syndesmophytes that are noted in cases of ankylosing spondylitis. So what are the things that you need to know about ankylosing spondylitis? Ankylosing spondylitis is having a bilateral symmetrical sacroiliitis. This is the earliest manifestation of ankylosing spondylitis. There is fusion of apophyseal joints. There is calcification of annulus fibrosus as well as the anterior longitudinal ligament. There are vertical syndesmophytes. We know patients of ankylosing spondylitis, they have inflammation of the tendinous and ligamentous insertion sites called as enthesitis. There will be erosions involving these areas of inflammation, and those erosions are called as Romanas lesion. And when there is repair and sclerosis happening around these areas, you develop what is called as a shiny corner sign. The mineralization under the anterior longitudinal ligament and the filling up of the concavity of the anterior vertebral body gives the shape of the vertebra into a squaring of vertebra in ankylosing spondylitis. You have also seen the bamboo sign, the trolley track or the tram track sign, as well as the dagger sign. You also see Anderson lesions, which indicate the involvement of the intervertebral disc space, the inflammation of the intervertebral disc space. And there is also osteopenia or a demineralization of the spine in ankylosing spondylitis. So tomorrow you are given a radiograph of the cervical spine, trying to identify by looking at all of these features. And also remember, ankylosing spondylitis is more common in young adolescent males, right? So the age group will be a young patient around 25 to 35 years age group, and this would be more common in males, ankylosing spondylitis. And what is the investigation of choice, by the way, for ankylosing spondylitis? Please remember, the investigation of choice for ankylosing spondylitis is STIR MRI. The sacroiliitis, which is the earliest manifestation, is identified better on a STIR MRI. So investigation of choice should be what? MRI. Now look at this lateral radiograph of the vertebra, and what do you identify in this image? If you see this image, there is a classic flowing wax-like ossification. It appears like there is a flowing wax. It is not just mineralization or calcification, there is hyperostosis, there is thickening. And this thickening on hyperostosis is taking the shape of a flowing wax. So this flowing wax ossification of anterior longitudinal ligament, ALL, the anterior longitudinal ligament of the vertebra, this is seen in cases of DISH. What does DISH stands for? As the name says, it is diffuse, idiopathic, skeletal hyperostosis. So hyperostosis is seen in DISH, not in ankylosing spondylitis. I'll show you one more image. Now let's learn a few important points about DISH or Forrester's disease. DISH or Forrester's disease, to diagnose DISH, you should have three important prerequisites. The first one is there should be a flowing wax ossification of the anterolateral aspect of the vertebra involving the anterior longitudinal ligament, which is contiguous, which is continuous at least more than 4 vertebra. So you should have a flowing wax ossification of the anterior lateral aspect of the vertebra involving at least 4 contiguous vertebra. This is a ligamentous ossification that happens. There is preservation of the intervertebral disc height, and this differentiates it from ankylosing spondylitis. In ankylosing spondylitis, the disc height was reduced. There is inflammation and reduction in the disc space. Whereas in case of dish, there is preservation of intervertebral disc height. And another an important differentiation from ankylosing spondylitis and dish is that in case of dish, there is no involvement of sacroiliac joints or apophyseal joints or the costovertebral joints. There is classic sparing. So these three things together, a flowing wax ossification of the antilongitudinal ligament involving the anterolateral aspect of at least 4 contiguous vertebra, sparing of the intervertebral disc height, the sparing of apophyseal or sacroiliac joints. This is prerequisite for diagnosing dish. And in case of ankylosing spondylitis, you see sacroiliitis, there is decrease in disc height and there can be the other lesions that we discussed like the bamboo spine and the other spine things. In dish, as the name says, there will be hyperostosis. There won't be any osteopenia. Whereas in ankylosing spondylitis, there is osteopenia. Dish or forestier's disease, this is more commonly involving the thoracic spine, right? And this commonly involves the anterolateral side, especially involving the right side. The reason is, on the vertebra, when you have the pulsations of the aorta, which is more towards the left, it does not allow the ossification on the left side. So the anterior part of the vertebra and on the right side, you see this ossification and the flowing wax-like ossification involving the thoracic spine in the anterolateral aspect, mainly on the right side. And there is sometimes involvement of the lower cervical spine also, as given in the images, right? So that can produce dysphagia obviously, and this can present as a chest tightness or dysphagia. Look at this image here. What do you see? Is this ankylosing spondylitis or dish? Look at the disc space. The disc space is preserved. Look at the ossification. How is it? It is hyperostosis. There is flowing wax-like ossification of the anterior longitudinal ligament involving at least 4 contiguous vertebra. So this is probably dish. Diffuse idiopathic skeletal hyperostosis, not ankylosing spondylitis. Another important image here. Please look at this image, the one that was given in the exam. What do you think is the diagnosis now? Look at the vertebra, look at the intervertebral disc space, look at the ossification, and look at the apophyseal joints also. Do you think is it ankylosing spondylitis or is it dish? I hope all of you are clear by now. You can see there is hyperostosis, there is flowing wax-like ossification of the antilongitudinal ligament, there is preservation of the disc space, the apophyseal joints are not ankylosed, and this goes in favor of dish, diffuse idiopathic skeletal hyperostosis. The age group given, right, around 45 to 50 years of age group will also match with the dish. Ankylosing spondylitis is more common in young age group, right? Adolescent males, okay, at least 25, 30 years, okay, more adolescent and young age group is ankylosing spondylitis. More older age group, 45 to 50 years, is dish. So let's sum up the differences between dish and ankylosing spondylitis. Dish, which is diffuse idiopathic skeletal hyperostosis, also called as Forestier disease. It is having no HLA-B27 positivity, and as the name says, it is idiopathic. Whereas ankylosing spondylitis, we all know, is strongly HLA-B27 positive. Dish is more common in incidence actually. Compared to ankylosing spondylitis, dish is more common. Dish is common in elderly patients and more common in males, whereas ankylosing spondylitis is common in young males, adolescent males. There is a flowing candle wax-like ossification of the anterior longitudinal ligament. In ankylosing spondylitis, you see lot of radiographic signs, bamboo spine, squaring of vertebra, Romanas lesion, shiny corner sign, dagger sign, trolley track or tram track sign. In dish, there is sparing of the intervertebral disc space. There is no involvement of the sacroiliac joints, no involvement of the apophyseal joints. A very important thing, there is preservation of the disc spaces in dish. Whereas in ankylosing spondylitis, there is intervertebral joint fusion. There is decrease in the height of the intervertebral disc spaces. Sacroiliitis, bilateral symmetrical sacroiliitis, ossification of the disc space, right? The fusion of apophyseal joints. these are more in favor of ankylosing spondylitis. There are no specific lab findings in DISH, whereas in case of ankylosing spondylitis, we see HLA-B27 positive, there may be elevated ESR and CRP levels. In DISH, the associations you can remember, obesity and diabetes can be associated with DISH, whereas ankylosing spondylitis, other autoimmune diseases like uveitis, ulcerative colitis can be seen. Important to remember, there is no osteopenia. Instead, there is hyperostosis. The name says it, diffuse idiopathic skeletal hyperostosis. So, no osteopenia, but hyperostosis is seen in DISH, whereas ankylosing spondylitis has demineralization of the spine or there is osteopenia. I hope this will make you have a clear distinction when you look at a lateral cervical radiograph tomorrow. Is it Klippel-Feil syndrome? Is it DISH or is it ankylosing spondylitis? Look at the intervalval disc space, look at the apophyseal joints, look at the flowing wax ossifications, and you'll be able to make those differentiation more easily.